today we're going to talk a little bit about ocular ultrasound. I have no disclosures. So let's start off with a clinical scenario. So you have a 58-year-old male. He's got a history of alcohol abuse and coronary artery disease. He's on aspirin, and he comes in because he tripped down the stairs and he struck his head and face on the railing. He drinks alcohol daily. His last drink was an hour prior to coming to the emergency department, so he's feeling kind of good. He's a little bit tachycardic. Otherwise, his vital signs are stable, and he's denying any headache, back pain, or neck pain. So this is what your patient looks like. He's actually overall very pleasant, but on exam, his eye is super swollen and you're trying to get it open to examine it and you really can't. So I just want you to think about what you would do next in this typical situation where you really need a good exam, but you can't do it because of significant swelling. We'll circle back to that later. So why do we do ocular ultrasound? So according to the CDC, between 2007 and 2010, there were 2.4 million eye-related emergency department visits per year. So this is a really, really common chief complaint that we see. In addition, sometimes we have lack of access to appropriate equipment. In addition, ophthalmology may be unavailable sometimes, especially if you're in a community hospital. And then occasionally ultrasound is even more accurate than your physical exam. And for an ophthalmologist or someone who's seasoned at doing these exams, they might be able to find things pretty easily. But for someone who's not doing this 20 plus times a day, it might be more difficult, especially when you're not dilating the patient, their pupils constricted, there might be blood in the way or soft tissue. And so ultrasound allows you to see beyond those things. In addition, as always, ultrasound is non-invasive and can be done quickly at the bedside. So how do we usually examine the eye? So we probably grab these things. You have your ophthalmoscope to do a fundoscopic exam, your slit lamp, you have a Woods lamp. You probably grab one of these devices to check pressures. And the funny thing about these is I feel like they fit in perfectly to this picture here with all these torture devices. And so whenever I'm going into the room with a slit lamp, I feel like I have to preface it with like, hey, I'm bringing in this really terrifying looking piece of equipment, and I swear it's not going to hurt you. And then the patient has this horrified look on their face as you roll the slit lamp in and tell them, hey, I'm going to check your eye pressure and I'm going to numb you and I'm going to stain you. These things can be hard to tolerate, basically. If you had an exam done yourself in the ophthalmology office, I know I have, and I had a really hard time tolerating it enough that they actually had to push my head against a slit lamp because I couldn't keep it there. So ultrasound is definitely probably easier for people to tolerate in addition. And on top of that, like I was talking about, ophthalmologists are seasoned at this. They do like tons of these exams and they do them all the time. We are not doing these 20 plus times a day. And so I do feel like sometimes these exams are low yield and I can't quite see what I want to see when I'm trying to do a fundoscopic exam or use the slit lamp. So ultrasound just brings that physical exam to the next level, especially in the emergency department. So let's go back to basics. It's important that you familiarize yourself with the anatomy before going into the room and doing ocular ultrasound, because it's going to help you differentiate all the different pathology that you can see on an ultrasound. So can you guys see my arrow? Anyone? All right, I'm going to switch to a laser just in case.
Can see it now.
Okay, so this is going to be your anterior chamber here, and then back here is your posterior chamber. So your anterior chamber, you have your cornea, and that's obviously where you get abrasions when you're staining, et cetera. You're examining that. Deep to that, you have your iris, which is the colored part of your eye. Your pupil is central, and then you have your lens, which is going to be suspended between these ligaments. In the posterior chamber, you have the vitreous body. Deep to that, this yellow area is your retina, and you can see that it actually goes into the optic nerve sheath. And then deep to that is your choroid. The optic nerve sheath contains the blood vessels and the optic nerve. And then again, the retina goes into that area. So it's important to remember that. So some indications include vision changes or like eye pain, ocular trauma, headache, altered mental status, anything where you have a concern for elevated ICP. Now, despite popular belief, there's actually no absolute contraindications to doing this exam. There's some relative contraindications. Lobe rupture, lid lacerations, or like significant facial trauma could potentially complicate this exam, but there's no actual absolute contraindication. So in terms of the technique, you want to choose your high frequency linear probe, which you're seeing on the right-hand side here. And you get less penetration with that, but you do get better resolution. So your image should be pretty crisp. You're going to use a lot of gel. I always tell everyone, whatever amount of gel you think you need, double it. You want to have a lot of gel when you're doing this exam. You want to be sure that there's a barrier between the probe and the eye. So a lot of people will put a tegaderm over the patient's eye, which is fine. You know, you can get air between, but in addition, it can stick to eyelashes and whatnot. So I personally like putting a sterile probe cover on the probe itself, and then I use sterile gel directly on the eye, and that typically comes in with the sterile probe cover. And so the patient will be supine. You can have them 45 degrees or lower, and you want to brace yourself against their head. So you can see in this right side picture that the sonographer is bracing themselves against like the patient's nose. But I have heard of people standing at the head of the bed and then bracing themselves against the patient's forehead. And that's fine if that's more comfortable. You just need to make sure that you reorient yourself because you're going to be facing the opposite direction than you typically would. So you want to make sure you know what is right on the screen and what is left on the screen. You want to make sure you're on the ocular or superficial preset, and then be sure that you're scanning through fully in each plane. So what not to do? So do not forget to put a barrier between the eye and the probe. Think about the ultrasound machines in your department. Would you want that probe directly on your eyelid? For me, that's a hard no. So please put a probe cover on. In addition, you don't want to be applying any pressure to the globe, and that's where that large amount of gel comes into play. You actually want enough gel that you're suspending or floating that probe in it. And so when you look at the image on the screen, what you're going to see is like a nice strip of gel, and then you'll see the globe. Don't forget to adjust the gain. You can start with like a normal level of gain at the beginning, but then if you feel like you have a normal exam, I would suggest at that point you increase the gain and see if you see anything, because there are subtle findings that can go missed. And if you increase the gain, you should hopefully be able to catch those. And then don't forget to use the extraocular movements. So obviously scanning through in two planes is a big part of this, but the good thing is that when people can move their eyes, you can kind of look in all of the nooks and crannies and hopefully you won't miss anything. And then don't use a water bath. I think that would be in poor form to stick your patient's head in a water bath for this, though it would be kind of cool to do ocular ultrasound in a water bath. Okay, so this is a normal ultrasound that you see right here. It's labeled, which is really nice. In the anterior chamber here, you can see the cornea. This is the pupil. And then you have the iris. And then this here crossing into the posterior chamber is your lens. Back here is your vitreous humor. So this area that should be just completely black on the screen. And then your retina is here. And then this kind of shadowing area is your optic nerve sheath. And then this here is a video of a normal eye on ultrasound. So you see the posterior chamber, you don't see anything abnormal floating around in there. Okay, so let's talk a little bit about the optic nerve sheath. So when is the last time that you did a fundoscopic exam and you saw this? For me, I don't know, maybe when I was on my ophthalmology rotation in residency and the patients were dilated, but in the ER, probably most of the time I'm not seeing this. And I would imagine that that's true for most of you. Now, if you're an ophthalmologist watching this, then maybe 5 minutes ago you saw this, but for the rest of us, that's probably not the case. So you can actually look at the optic nerve sheath on ultrasound, which is really awesome. And basically what you do is you find the optic nerve sheath, you measure 3 millimeters posterior to that, and then you measure across. And greater than 5 millimeters is considered abnormal. 5 to 6 is kind of a gray zone, but anything greater than 6, there's concern for elevated intracranial pressure. In addition, there are some different measurements for children. So under 1 year of age, less than 4 is normal. And then in kids 1 to 15 years old, less than 4.5. And then once you're greater than 16, you just follow the adult measurements. And something I saw that was kind of cool and an easy way to remember this is just think of a 3x5 index card. So 3 millimeters posterior, and then 5 or less is normal. And so this image here is actually an optic nerve sheath. And this here is the sheath. You can see that they measured 3 millimeters posterior, and then they measured across, and it's measuring 4 millimeters, which is normal. Okay, so let's go through some trauma. Keep our intoxicated patient from the beginning in mind while we're going through this. But these are the various different pathologies that you can see in trauma. Some of them you can see without trauma also. So these sections kind of overlap a little bit. So a HYPHEMA, you know, if you're able to examine the patient and you can see it on exam, then great. You're kind of done at that point with in terms of visualizing a HYPHEMA. But it's blood in the anterior chamber. Now, if your patient looks like our patient from the beginning and you can't open their eye, then you might want to consider doing an ultrasound at that point. And so a HYPHEMA looks like an echogenic area on ultrasound. So you can actually see we have an arrow sign here and it's pointing to the HYPHEMA. Now, if you're not familiar with ultrasound, this can easily be missed or mistaken for normal. So just make sure you familiarize yourself with what a normal ultrasound looks like before you say that an ultrasound is completely normal and end up missing a HYPHEMA. So the cool thing about this is you can also check the pupillary reflex using ultrasound. So again, you have a patient who has a super swollen eye, or they're having trouble tolerating the exam because of trauma, and you would need to know whether or not their pupil is responsive. This here is a video that shows a pupillary reflex. 1 second to play it. So on this, they're very zoomed in on the pupil here, which is obviously this round structure. They shine a light into it, and then you see that it responds. So they're actually shining the light into the unaffected eye. And then on this slide, we're going to talk a little bit about extraocular movements and vitreous hemorrhage. So same thing as the last slide, with extraocular movements, you might not be able to assess very well when someone has significant swelling. And so you can actually see that on the video to the left here, which I'm going to play. And this video obviously has a very obvious abnormality in the posterior chamber. You can see this echogenic material floating around, and that is a vitreous hemorrhage. And so a vitreous hemorrhage, again, presents as echogenic material. And when you move the eye, you can see kind of this washing machine look where things sort of swirl around. And on the right is one that's a little bit more subtle, but you can see this material in the posterior chamber. So retrobulbar hematoma, this is something that you really don't want to miss. This is a true ophthalmologic emergency. Typically, we're seeing it in the trauma setting. That being said, it can occur after some sort of ocular surgery, and patients typically present with pain, proptosis. They have decreased vision. They might have conjunctival edema, chemosis, and you might be able to even palpate that they have this because you can feel that the pressure is different when you palpate the one globe compared to the other. It'll feel much harder on the side that's effective. This is very, very time sensitive, and you have to decompress it rapidly in order for the patient to have a good outcome. It is vision threatening, and so you want to decompress as soon as possible once they come to the ER. And I actually had one of these a few days ago in the department, and it wasn't managed rapidly enough at an outside hospital. And we did decompress when they came to us, but it seems like they're probably going to have a poor outcome. So what you will see on ultrasound is that the normal shape of the globe is kind of changing. So you can see that what's called the guitar pick sign on this. So the eye is sort of shaped like a guitar pick, and then posterior to the eye, you see some hypoechoic blood, which I will point out here, here, and here, and that's kind of misshaping the globe. And then this back here is your optic nerve sheath. Foreign body. So patients will typically present with redness, tearing. They might have decreased vision. They may say, I feel like there's something in my eye, or see flashes of light. You will typically see an abnormal echogenic structure, and there might be some artifact from it. If it's metallic, you would see reverberation artifact. You might see some shadowing posterior to the foreign body. And there may be associated, other associated pathology like a vitreous hemorrhage, a globe rupture, choroidal detachment, a retinal detachment. So make sure you scrutinize the images really well. This here is a video of a foreign body that's pretty obvious in the posterior chamber. And it lights up bright. And obviously you'll be giving a call to ophthalmology for this. And lens dislocation. So this can also occur in trauma, but people can get it following certain surgeries like a cataract surgery. And people who have connective tissue disorders who are presenting with vision change, this is something that should be on your differential because they are more prone to it. Patients will typically present with a vision change. They will have a normal pupillary reflex. And when you're doing your ultrasound, you're going to see a hyperechoic circular object that's floating around in the vitreous body. So you can see a lens dislocation on this imaging. I imagine if you increase the gain a little bit, you might even see that it's circular a little bit better than you can see on this particular image. And then a globe perforation or rupture. So most people believe that this is an absolute contraindication to ultrasound, and it actually isn't. That being said, you have to be really, really careful, obviously, because you don't want to put any pressure on the globe and cause any more contents of the globe to come leaking out. So you really need to use a large amount of gel, and you want to suspend that probe in the gel so you're not putting any pressure on the globe. And I would suggest that you should be more experienced if you're doing this on someone where you suspect a globe perforation. This isn't the first type of imaging that you should do if you're a novice sonographer and you're suspecting a globe perforation. I would hold off probably. So what you're going to see is loss of the normal spherical shape of the globe. There might be buckling of the sclera, decreased size of the globe when you compare to the other side, and you can even have associated hemorrhage. This is another ophthalmologic emergency. You obviously don't want to miss this, and sometimes it can be pretty subtle on exam. But in this particular image that I have here, you can see that the globe is not as spherical as it normally should be, and then there's some like hemorrhagic contents in the globe itself, and this is a globe perforation. Okay, so ultrasound and vision changes. So there are several different detachments. They're relatively easy to get mixed up, especially if you're not familiar with them. So we're going to review some anatomy first. So I have two different pictures here. On the right, you can see just the normal anatomy of the eye. This yellow part, again, is the retina, and you can see it attaches here to the optic disc. And then deep to that is the choroid. And then this like pink area in the center here is your vitreous body. To the left here, you can just see a cartoon depiction of a vitreous detachment and a retinal detachment. The vitreous detachment you can see like goes past the optic disc, whereas the retinal detachment actually is kind of tethered there. A vitreous detachment tends to be much more mobile with ocular movements versus the retinal. And it kind of makes sense since the retinal detachment is attached to the back of the eye still. And then a choroidal detachment typically does not move with rapid movements. So a retinal detachment, you're at risk for this with age, but also with trauma and a history of eye surgery. Patients typically present with painless vision loss. They may have like floaters in their vision or see flashing lights. Sometimes they describe like a curtain in their visual field or like a shadow in the periphery. The membrane tends to be a bit thicker than the other detachments, and it might move some again with eye movements, but it's going to be less mobile than your vitreous. It's going to likely be fixed to the optic disc. And this is the more emergent one of the three we're talking about right now, because it can lead to irreversible vision loss. And so this is something that you don't want to miss, because you're going to want to talk to ophthalmology while they're in the department. In addition, you can actually miss smaller ones if you don't scan through both planes fully. So make sure you're fully scanning through in both planes and utilize the extraocular movements, because that might actually be the difference between you missing or finding a subtle retinal detachment. So this video here shows a retinal detachment. You can see kind of two membranes on either side of the optic disc, and then it's tethered to the optic disc in the posterior chamber. And you can see that it's not moving a ton. I mean, it's moving a little bit, but it's not, floating around or moving all over the place, as opposed to what you'll see with our vitreous. So this here is a vitreous detachment. Again, as you get older, you are at risk for this. So the vitreous is not tethered to the optic disc, so it's going to be more free floating and more mobile. It tends to be a thinner membrane than the retinal detachments that we saw on the last page. And when you move the eye, it'll probably move around a lot more than you saw on the prior video. This is less emergent than a retinal detachment, but it does require urgent follow-up. That being said, it's not vision threatening like a retinal detachment. So in this video, you see this membrane floating around in the posterior chamber, and you can see that it's actually not tethered back here. It's just kind of free floating. And that tells you that it's a vitreous, not a retinal. Okay. So choroidal detachments, basically you get blood or fluid between the choroid and the sclera. So going back to our previous anatomy, on that first slide of this section, you can see how that would cause a detachment. And basically, if there's blood, it tends to be a little bit more painful than if it's just fluid. Low pressure in the eye can cause this. So if someone just had some sort of surgery or a procedure for glaucoma, they may be more prone to this. In addition, being on anticoagulation is a risk factor. And again, being older is a risk factor too. This is more dome shaped, and on the right side of the screen here, you can see that you can get this kind of hourglass look to it. And that is how you know that it is a choroidal versus the others that we mentioned. It's also a thicker membrane. So this to the left is a video of a choroidal detachment, and you can kind of see that dome shaped pattern to the left of the screen. Okay, so ultrasound and headache and altered mental status. So if you have a concern for elevated intracranial pressure, this is actually something that's good to utilize in order to see if there is evidence of elevated intracranial pressure by measuring the optic nerve sheath diameter. So this can be used in patients with like an intracranial hemorrhage, or if they're presenting with headaches and you suspect maybe they have idiopathic intracranial hypertension, or if they have a brain mass of some sort and you're concerned, then you can utilize this. So this is an abnormal optic nerve sheath diameter. As we had mentioned earlier when we were talking about the normal, you're going to measure 3 millimeters posterior to the disc and then measure across. And you can see in this image that this is measuring at 6 millimeters. So this is definitely abnormal and concerning for elevated ICP. So just some other pathology and incidental findings that you may see. So ocular masses are pretty obvious that you can see in this image here. Lymphoma, retinoblastoma, optic nerve meningioma, there's so many different kinds. And basically patients will present with vision change or loss. They might have headaches, maybe some neurologic symptoms. Those are just a few of the symptoms they can present with. And you can see in this image that it's just pretty obvious on the ultrasound that was done. Central retinal artery occlusion is something else that you can look for on ultrasound. You can use color Doppler in order to do this. So the artery and the vein do travel through the optic nerve sheath along with the nerve. And this is also a vision-threatening ophthalmologic emergency. Anything that puts patients at risk for stroke will put you at higher risk for this in addition. So factors like CAD, hypertension, hyperlipidemia, diabetes, all put you at risk for developing this. This can be caused by an embolic event or atherosclerosis and presents with sudden painless vision loss. So this image is pretty cool here. It's from a article that was, or a case report that was published where they diagnosed this on ultrasound. And so on the left, this is like the normal, you can see pretty good color and blood flow. And on the right, there's much less, and you can actually visualize the clot. It's like a hyperechoic embolus right here on the right side. And so this is pretty cool. If you look up videos, there's a bunch of videos where you can see this a little bit better in real time. Asteroid hyalosis is a benign finding, and it's typically an incidental finding. You have someone with an ocular complaint. It may or may not be in the eye with the asteroid hyalosis. You scan through and you see this kind of scary finding. And this is just something incidental. It happens with age. The etiology is kind of unclear, and there's really no intervention required. And Stephen Elliott, who's on here, I think you did this because here's your initials. So this video, as you scan through, you see all of this contents in the back of the, in the posterior chamber, and it looks kind of like a starry sky and a little bit scary, but it's just an incidental finding. And often, you know, this might be found in the opposite eye.
I remember it like it was yesterday.
Yeah. Yeah, so this is like probably an incidental finding. You might be like comparing the one side to the other. This is on the unaffected side, and you're like, what is that? And there's nothing to do for it. It's just something exciting that you found that you think about years later, apparently. So let's go back to our clinical scenario. So we have our friend here, maybe one of our frequent flyers. He struck his face, his eye is swollen shut. There's really nothing else focal on exam, but you just can't get an exam of that eye because it's so swollen. And so thankfully, this is a very happy drunk. He's very cooperative with what you want to do. So you're like, hey, I'm going to do an ultrasound of your eye. And he's like, yeah, let's go. So you put an ultrasound on, and you're obviously looking for many different things, but you find this. So you see a membrane in the back of the eye. And as you remember, there's a few different detachments we can see. So how are we going to differentiate this? So let's look at the video. So it's a little bit mobile. The membrane's a little bit on the thin side. And as you scan through, it looks like it's tethered down to the optic disc. And so this is a retinal detachment. Now, in this particular patient, you couldn't get a good exam. He's also drunk, so he might not cooperate for visual acuities very well. So you might not even know that he has a vision change. And this might have gone missed otherwise. So you speak with ophthalmology and they're like, yeah, we'll come manage this right away. And you changed the management in this patient by doing this ultrasound, which is great. So this is a pocket card that POCUS 101 has with different diagnoses that you can see on ocular ultrasound. You can print it out and carry it with you if you want to, just to, you know, have it on hand while you're doing this. And I just thought it was kind of cool. So last is just some pearls and pitfalls. So use of Doppler, you know, if using it, you just want to be brief. It is a higher energy mode and can theoretically be damaging. So you don't want to be sitting there with Doppler on the eye for a prolonged period of time. In addition, perforated globe is traditionally thought to be an absolute contraindication to this, but it isn't. You can do this ultrasound on someone with a suspected perforated globe, but you just have to be really careful. And again, use a ton of gel and float that probe. Do not put any pressure on the eye. And you could diagnose this on an exam that maybe is, you know, unclear whether or not they actually have an open globe. And, you know, as I mentioned, use a ton of gel. Differentiating different detachments can be difficult. So just continue to familiarize yourself with them, because obviously if you're not using this every single day, it's easy to forget or you know, mix these up, and you don't want to do that because one of them is vision threatening and the others are not. And then finally, you might miss small retinal detachments or other pathology. So make sure that you increase your gain. You use your extraocular muscles in order to visualize every area of the eye. And that is all I have for you guys. Thank you so much for attending.